Awesome. Thank you so much again. I super appreciate. All right. So I know you guys have all heard a bit about TMS already. And like Dr. Withy was saying already, I know there's been a lot of marketing going on uh, with TMS. So, oh, thank you. I got the message. I love your title slide. So kind. Thank you so much. So I'm going to do a little bit of an overview. I think I will uh, quickly go over this since it sounds like a lot of folks have gotten a history already of what TMS is all about. So I'll kind of fast forward through this. And again, a huge mahalo to everybody for having me today to talk about it. I do have to just say, as a clinician, it is a wonderful thing in behavioral health um, that we have another treatment alternative uh, without medication, an increase in the medication with results that I've been super pleased with. So without further ado, let me continue on. I don't want to keep you for too long here. So brief overview of what I'll be going through, a quick understanding of TMS, the definition of TMS, history, these kinds of things, and then TMS and depression, developments in TMS that are happening right now. Also, next steps that we can take. And then I just want to finally add at the end any discussion or questions and answers about it so we can talk stories.
So I just want to mention that even though we've had it like once a year for the last 3 years, not everybody was
Oh,
on those days. So like Michelle pointed out, she wasn't on for the overview. So don't go too quick.
okay. Thank you so much for saying. I appreciate that so much. Wow, I didn't know you had it for every year for the past 3 years. That's great to hear.
But it was by
Uh,
the same person. What's her name? Oh my gosh, Queen's doctor.
Was it
Uh,
oh,
Dr. Sakai?
no.
Remembering
Oh my
correctly?
gosh, I'll look it up and put it in the chat. But go ahead.
Yeah.
okay. No, thank you so much. That is so funny. Um, just I know I'm taking a side right here in the beginning, but I also am faculty over at School of Nursing and Dental Hygiene, and we are gearing up to start a behavioral health clinic with a TMS um, machine, which I think JABSOM used to use actually. So that's so we're excited about getting that started at any rate.
You're getting the old
Understand?
machine and they bought a
Yes,
new
we're
one.
oh, that's so
I
funny.
don't know. I don't know. I'm just guessing because
Yeah.
yeah, it's just funny because it's been, experimental basically, and now it's going
Yes.
mainstream. So we've heard about it over the years. Let me find her name, but yeah.
I love
And
it.
go ahead.
I love it. I love it. Yeah, so you all have the full history. It's great. All right. Okay, so TMS, transcranial magnetic stimulation, non-invasive procedure that uses magnetic fields to stimulate nerve cells in the brain. A little bit about the history. I won't go into fine details about it. 1985, developed by Dr. Anthony Barker at the University of Sheffield, England. Gained attention in the 1990s for therapeutic use. 2008, received the FDA approval for the treatment of treatment-resistant major depressive disorder. And that's come along because it has now been FDA approved for OCD treatment. And we have also received FDA treatment, at least NeuroStar, which is one of the brands of the machines that is out there now. We're able to treat uh, adolescents 15 years of age and over. So, just very basic here. The brain communicates using electrical signals. Disorders can manifest When there is an imbalance within the neurons and communication, TMS targets specific areas of imbalance and seeks to restore functional brain activity using the use of a magnetic coil to deliver magnetic pulses. And we're seeking to activate or inhibit neurons. So there's two different frequencies, the high frequency or the low frequency. The high frequency is what is FDA approved right at the moment. That's at 10 hertz or higher, and it can be activating and excitatory. I'll talk a little bit more about what region we are stimulating when we're using the TMS. And some of the other options that we have to use, it's not just one size fits all anymore. We can stimulate different areas for different effects. So for the high frequency, it's helpful for mood regulation. For the low frequency, which is at 1 hertz or lower, reducing, and it is also inhibiting, helpful to quiet excessive worry or agitation. And we're finding that even though insurance only pays for the high frequency at the moment, um, if we add right side low frequency treatment, that can really help to concurrently, and I'll talk a little bit more about this, can concurrently help folks if they're having an uptick in anxiety symptoms as well. So TMS is generally well tolerated, but there are some exceptions. And these are things that I go through every client that we have to come through that may be interested in TMS, who meets the criteria. There's very strict criteria for folks for TMS. Mild to moderate discomfort or pain, of course, and everybody is different. We've seen the whole range. Most folks generally are tolerate it very well, but uh, everybody is different. I will go through a mapping, we call it a mapping session. That first session when we are locating the area that we are going to stimulate, where folks on a scale from 0 to 10, 10 being the most discomfort, where some folks are like, this is a 0, I'm totally okay. It's just a little bit strange feeling this tapping on my head. Like a woodpecker, we don't usually go through our days with a tapping on our head, versus folks that are like, whoa, what was that? Headaches, that's one of the most common side effects, a mild headache. Interestingly, we have, I would say, about 50% of our patients that we're treating right now that have a history of migraines. The migraines have not gotten worse with any of our clients, but mild headaches can occur, which we treat with acetaminophen or uh, the regular ibuprofen or other NSAID. Scalp sensitivity can happen, muscle twitching, especially during when we are doing what we call the mapping session when we are stimulating the motor threshold. We stimulate the motor threshold first to start gearing us in the location where we need to be. So that involuntary muscle twitching can happen during that, and it's wanted, by the way, during that initial mapping session. During treatment, though, the muscle twitching should not be there. So we'll make adjustments if there's twitching that happens. Hearing sensitivity, because there is a pulse that you are listening to. Um, Fatigue, some folks may report fatigue after the treatment, though everybody can drive themselves in and drive themselves out from the appointment. Most folks go back to work or go and do whatever they need to do, back to their families. Rare but very serious. I'll talk a little bit more about this too, but seizures may happen. The risk of seizure, I do have to say, is, uh, as you probably know already, very low risk, less than most of the psychotropics that are available out there at the moment. So, talking about TMS and depression just a bit. So, just to back up a bit about major depressive disorder, persistently depressed mood lasting a minimum of 2 weeks. So, the reason I'm spending a bit of time on this is the treatment is FDA approved for treatment resistant depression. And that is, as if we're dealing with insurance, which I know a lot of us have to deal with, that is what is being reimbursed at this time. OCD, even though it's FDA approved, most of the insurance companies are not um, reimbursing for OCD treatment. So if we have a patient that has treatment resistant depression, who this treatment is appropriate for, um, we will treat that, the major depressive disorder. And if they also have co-occurring OCD, we can treat that as well under that. But what we are primarily treating, again, for insurance purposes, is the major depressive disorder. At any rate, backing up for major depressive disorder, symptoms can include anhedonia, the loss of pleasure in things that we previously enjoyed. And that is a true loss. That is a true loss. Fatigue, sleep disturbances, guilt, changes in appetite, feelings of hopelessness or worthlessness, persistent thoughts of death or suicide, inability to concentrate or make decisions, change in physical activity, and the list goes on and on. I know this is not all inclusive, but these are some of the biggies that may happen with major depressive disorder. So there's many different forms of depressive disorders. I'll kind of glance through these, but there's disruptive mood dysregulation disorder, persistent depressive disorder, uh, premenstrual dysphoric disorder, substance use induced depressive disorder associated with another medical condition. And we have other specifiers that come along with that. Uh, One of the major ones that we look at too is with peripartum onset, which is during pregnancy or within 4 weeks postpartum that we want to look at. So just looking at some of the statistics here, number one cause of disability globally. That's huge. That is huge. Um, and it deserves our attention for sure. Lifetime prevalence rates varies to over 20%, 2 times greater risk for women than men, although I gotta say that I think it's very underreported for men. And LGBTQ plus youth, up to 58% may experience depressive symptoms. Really says a statement about our communities and how more support to folks. 50% have an age of onset between 20 and 50, about 40 years, and up to 70% of individual depressive disorders have comorbid anxiety disorders. They really do go hand in hand much of the time. And if we're looking at some of the focal causes that we're thinking, if we're thinking that serotonin may be at play here, a mediating factor, um, we're treating both. We're treating both with a lot of the similar intervention, say, for um, looking at the medications with antidepressants, how we treat. If we're going to go the medication, everybody again is different, and there's individualized for each person. But um, if we are looking at somebody who has depression with comorbid anxiety, no matter what anxiety diagnosis somebody may be having, we found that the treatment, and there's research out there that's coming up now, where the TMS can be helpful. And we found anecdotally in our own clinic that the anxiety symptoms are improving as well while we're treating the depression. So treatment of depression with TMS, we are stimulating left dorsolateral prefrontal cortex. So we're placing at the machine that we have, there's different machines out there. Some machines cover the entire scalp. The machine that we are using just covers that left dorsolateral prefrontal cortex, and that's what we're stimulating, thought to have control our mood and regulation, decreased activity during depressive episodes. Possible mechanisms of action may include synaptic plasticity. I know that's a big phrase nowadays, the plasticity. Um, Neurogenesis may promote changes in dendrites, assisting in regulating chronic stress and depression, and then also the neurotransmitter release by stimulating our neurons in those areas to stimulate production and that release of those neurotransmitters, those biggies we always talk about, serotonin, norepinephrine, which is your noradrenaline as well. Same thing when we're talking about that. And of course, dopamine. So just a picture, I got this from Neurostar. That's who we use for the machine that we use in our clinic. Um, so here is a picture of a depressed SPECT scan of a PET scan rather, sorry, of a depressed, somebody who may be depressed and a non-depressed, with all that activity happening going on the right side of your screen that you're looking at.
We have a
So,
good
yo,
question.
oh, I'm
Yeah.
so sorry. I should be
Oh, no, no, no,
monitoring
no,
the
no.
chat
I will
better.
read them to you. Don't you worry about it.
Oh, thank you. You're so
Um,
kind.
it says, does the brain area change for dominant handedness?
Oh, that is such a wonderful question. I love that. So, thank you so much for asking that beautiful question. We are treating always the left side. Um, Very interesting. That's a really great question. And truth be told, as before I say something that is like totally off the wall, um, I think I'm going to want to get a little bit of more information on that. So we have had clients that are dominant on their left side versus the right side. And the direction that we've always gotten from our consultants is we're going to we're always going to start with the left side. With that said, though, some people do respond better to the right side. The high frequency treatment, though, is always on the left side. So wonderful question. I really
One more
appreciate that.
question. Uh,
Yes. Oh, yes.
yeah. Janita says, some of these effects are similar to what we see with ILF neurofeedback. Are there comparison studies? And it might be too early for that.
Yes, that's a great one. I'm actually going to take notes on that because,
Right.
um,
You can
yes,
come back and let us know.
yes, absolutely. I love that. That these are wonderful questions, truly. Thank you. Was there another one, Dr. Whitney?
That's it. That's it for
Oh,
now.
that's it for now. Okay, keep them coming though. I
Oh,
love
but
that.
by the way, I looked up, it was Cecilia Ona, who's been talking to us for probably since 21 or so. Let me look back, but she
Wow.
introduced the concept to us. Definitely 22. And then I have Eric Shipley down in 23. But so anyway, go ahead.
Thank you. No, that's great. Thanks so much. And looking the names up, I appreciate that. So some treatment comparisons here. Uh, of course, for therapies. And I am a huge fan, of course, of therapy. Every client that we have currently um, receiving therapy in conjunction with the TMS. So we can work through things. It's not like it's a one-stop shop for just get TMS, that's it. I'm a huge fan of therapy as well, so we can work through things. So therapies can include, of course, CBT, cognitive behavioral therapy, interpersonal therapy, behavioral therapy, group therapy, time limited focus. Like there's so many, of course. And I think we all know um, it's you'll be hard pressed to find somebody who's like, I only do this type of therapy or whatnot. It's really the client, per the client, what is right for them. And we really can we join in so many. It is like a medley, a symphony, if you will, of all kinds of therapies that we use, like motivational interviewing. I use that with every person that I'm have treated therapy with. Uh, it just it is a medley. Medications, if that is appropriate for folks, including SSRIs, selective serotonin reuptake inhibitors, SNRIs, and all these acronyms, right? NDRIs, TCAs, MAOIs. One of the new ones too, which I could talk more stories about as well in on another day, ketamine and S-ketamine, and of benzodiazepines as well. There's so many other medications in there, but the biggies that are used as a first line generally are SSRIs and SNRIs, depending on what that diagnosis is. Electroconvulsive therapy, ECT, and there's others, of course. Vagus nerve stimulation, biofeedback, which is to the point of one of the wonderful questions that we received already. Biofeedback. I'm a huge fan of biofeedback for sure. Hypnosis, dietary herbs and supplements. Um, Oh, I put hypnosis in there twice. Isn't that something? I guess that's my Freudian slip today to put two, and there I am a fan of hypnosis, for sure. Concurrent and then concurrent treatment modalities too. So again, I'm a big fan of like TMS along with concurring therapy and other treatments as well that may help. And vagus nerve stimulation, which one of us can't use a little bit of that? Like we can sing together. I know it's hard over Zoom, but we can stimulate that nerve by singing or humming together. It's a beautiful thing at any rate. I am a fan of concurrent treatment modalities when appropriate, so we can really curtail the treatment regimen per the client. Um, that's important because we are we are all special in our own way for sure.
Another quick
So
question. Is their
yes,
therapist is their therapist also trained to do the TMS or a separate person does it? So I think if
um,
you're a therapist, do you do both or is it separate?
so that's a really great question. And if I'm understanding the question right, and please correct me if I'm not understanding it right. So um, taking myself as an example, I'll do therapy um, with my clients as well, and the med management. What I really like though is to have um, another therapist. So I'm so grateful to work with a couple of very wonderful psychologists that we have our treatment team where I'm doing um, the prescribing for the TMS, and I may do the med management as well, and then our therapists will, who are that we're working with, although we do have we're bringing on some social workers now too, but at any rate, which is a beautiful thing. Um, so somebody else, so that we have some uh, different perspectives on there, to have a larger treatment team to work through things, is a beautiful thing. So if the question was more about if psychologists, the therapists, can do the actual TMS, um, they are not able, I don't agree with this, truthfully, um, that they are not able to prescribe the TMS. It has to be, and it's per the insurance as well. It has to be either a physician at this time or an APRN, depending on the insurance. And some insurance will not reimburse for an APRN to prescribe the TMS treatment. But the psychologist can do, after it's prescribed and we do the mapping session with the prescriber, does that. But after that is done, the actual treatment sessions, they can be done by the psychologist. We have TMS technicians that are certified to do the treatment, to actually place the coil for the treatment sessions. And I'll talk a little bit more about what that entails, because this is a long process. My heart goes out to everybody that goes through this. Uh, these folks are very motivated, that undergo the TMS treatment. It's 36 sessions. Uh, that's a lot of sessions. And you're coming into the office for each of those sessions. That's 6 weeks of 5 days a week. And then we taper down for the last 3 weeks for 2 sessions each week for the last 3 weeks. But that is a lot. So lots to talk about when we do an initial consultation. Of course, we go through all the criteria and go through risks and the benefits and make sure that there's not going to be a contraindication for the treatment. And there are some. But in addition to that, we're talking about the length of the treatment, the commitment that's involved. It's really, it's a lot that folks do.
Do you know what it costs if insurance won't cover it for the 2-month course?
Oh,
Oh,
that is a
that.
great question too.
Yeah.
That is a great question. Yes, it's very costly. We are trying to work out in our clinic a sliding scale for folks that don't have it covered by insurance. We've been fortunate that everybody has been covered by insurance. Some insurance is much more liberal for anybody that's worked with insurance. Oh my goodness, that's a whole another, we could spend a whole semester talking about all of that, and philosophies behind it and everything. But um, so I don't have an actual cost right at the moment for what it would be for somebody without insurance for this. But insurance, uh, can I just say, and um, I'm not trying to prop one against the other, but like TRICARE, for example, uh, through the military insurance, they are very liberal as far as how many treatment sessions they'll provide for their clients. 60 sessions generally they will approve, versus some others that will approve the straight 36. And I'll talk a little bit more stories. That's really a great question that came up and brings up a lot of things in my head as we're talking about it. Um, where uh, the 60 sessions can be helpful sometimes when people have things that, after they go through a whole course of treatment and life happens, we know, I mean, things go up and down, and maybe somebody has a loss in their life, uh, things happen at work, whatever it may be, and there's recidivism of the symptoms that somebody is experiencing, and they need some maintenance sessions. So we'll work on a treatment plan that's right for that particular patient. Anyway, I veered. I'm so sorry. There's like so much information. I would love to go through it with everybody. Any rate, great question. I'm sorry I don't have an actual figure for you. That is something that we're talking about to have a sliding scale for folks that want to pay out of pocket uh, for for this. We've been fortunate that insurance has reimbursed everybody that has been eligible for this, and they met the criteria. Um, at any rate, looking at the remission, and stop me anytime if there's other questions for sure. And thank you for monitoring the questions that are coming in the chat. I appreciate it. Uh, the likelihood of remission with each new antidepressant, well, it goes down with each antidepressant that you try. And for all the prescribers out there, I think, it's like, it's a process. It is a process finding. And if you have experienced or had a client or you yourself have experienced trying a medication, if that is appropriate for somebody, and it's usually not a one-shot deal. Oh, you try this and that's it. That's going to be it for you. I mean, it's really working through to find what is appropriate for a particular person, for sure. At any rate, um, there's increased side effects. Also, the research shows with each new antidepressant that is used. And that's concerning. Side effects are no joking matter for sure. Um, of course, that GI upset, sexual side effects that happen, the headaches that may happen, and the GI side effects, by the way, that's a big deal. And it makes perfect sense why we have all these side effects with antidepressants. If we're talking about our neurotransmitters, the majority are made in our gut. So that whole brain gut axis that we're talking about, it makes perfect sense. That connection through the vagus nerve, if the large majority of serotonin is made in our gut, it makes sense that if we're taking a antidepressant, that we're going to have some GI side effects at any rate. Um, Stuff we talk about with every client that we may be prescribing a prescription to for medication. I know that's not what we're talking about today. And one of the reasons I got to underscore again, I'm so glad that there's other treatment options that are coming up that may be as effective as a medication. It doesn't have to be metabolized through your liver and excreted through your kidneys and all those side effects that come on with that. So outcomes, they're pretty good. Not really just pretty, but really good. And anecdotally, from what we've experienced in our clinic, uh, it's been very effective for folks who are appropriate for it. And I do want to stress that again, is like that initial consultation, it is crucial to really have a thorough initial consultation, and our clients, whoever may be, whatever clinic this may be, to really thoroughly know what this treatment is about, and really be screened to make sure that this is has a good chance of success for somebody. So improvement in depression symptoms, upwards of 83%, and symptom relief, and we're considering remission, 62%, which is higher than the most psychotropics that are out there right now, psychotropic medications. So current research and developments, I'm looking at the time now. I can't believe it's 12:41 already. I think Shar can attest to this. I start getting into everything. I'm very passionate for sure, as I know we all are with behavioral health. Um, you know, mental wellness is I'm so glad that it's coming to the forefront for all of us. Goes hand in hand with overall wellness, doesn't it? Uh, Developments in TMS, expanding clinical applications. So I mentioned very briefly in the very beginning that we're now able to treat major depressive disorder in adolescents, 15 years of age and above. Insurance here in Hawaii is not picking up on that yet, but has been picking up steadily in the continental US. So we're hopeful that it will pick up here for reimbursement from insurance for adolescents. Treatment-resistant depression and accelerated TMS, anxiety disorders, general anxiety disorder, and OCD. So, well, OCD is that should not be under the same thing, of course, in DSM-5. OCD is in its own bracket now, but anxiety disorders, I would say the large majority of clients that we have that do have treatment-resistant depression, they also have co-occurring anxiety as well. And the treatment itself has proved very effective for them as well, for the anxiety symptoms too. And this is one of the cases where if somebody is having an uptick for whatever reason in anxiety symptoms, rather than just stimulating with the high frequency on the left side, we can stimulate on the right side, and it's a low frequency and that has been very soothing for a lot of people. Also, for folks that have co-occurring PTSD, it has helped with the symptoms that folks have been experiencing with PTSD, adding that right side treatment. Now, insurance, again, they're reimbursing for the major depressive disorder, but we will add that treatment on the right side as well. Also for OCD, which is actually stimulating in the center of the scalp for OCD. Um, so we'll add that, and it's no problem on for our clinic at all. It's just the client will be in the chair for longer. The typical session is about 18 and a half minutes. I know that's a long time, and you're thinking about 36 sessions, 18 and a half minutes.
It's not as long as getting to the doctor and getting out,
That
but or
that
the
is true.
yeah.
That is it.
So um
That's a
you
wonderful
have
point. Yes.
I would look back. Our first TMS talk was by Dr. Warren Tamashita in 2020, April 2020. And we
Mm.
have not had this many questions for other speakers, but here we go.
All
Um,
right. I
if
love it.
yeah, if you have microplastics in the brain or Alzheimer's, or a past stroke, um, or meth-induced neural damage, do
Mm.
do we know anything about any of those? These are all separate questions. This is a very impressive group questioning session.
Yeah. Oh my gosh. Yeah, you all are amazing. If number one, I gotta say, and thank you so much for all those questions. So, interesting bringing up about um, the cognitive questions. There's research that's being done right now for the effectiveness of TMS with cognition itself, like Alzheimer's and dementia, no matter what the cause may be of uh, the cognitive symptoms that may be presenting. Um, that that is still being looked at, and I don't have any firm data for you on that one, but I personally am very interested in that for sure. The question about um, plastics implants. So
Or just
that
microplastics, that we get.
uh yes, that's it.
That's a good question.
That is a re I'm gonna write this one down
All right.
actually.
And then
And
meth.
I don't have a good answer for you on
Yeah.
this
No,
one.
I wouldn't expect you to, but then there's meth-induced neural damage
Yes.
and then a
Uh,
past stroke.
yeah, that's true. So so all of the we're talking about the neuro damage, you know, I would like to look at more research on that. I really would. I'm uh I don't have a firm answer for you, but my own feeling on this is, yeah, let's get more info on all of this for sure. Because we are stimulating the neurons. That's what we're doing. We're stimulating the neurons. And when we're talking about neuroplasticity, I know that's the big catchword, catchphrase that we're all using nowadays. Um, we're looking for actual growth in those neurons. And it seems to, I don't want to get ahead of myself here because the research is not there quite yet. But I would really like to see more research on this um, to see what's actually happening for folks that may have substance use induced neuro damage and how that can be effective. And a past stroke, too. Absolutely, that goes hand in hand with some of the research that's going out right now with looking at some of the some folks that are experiencing cognitive, I hate to say deficits or whatnot, but some see what the effect can be from the TMS because it seems logical, doesn't it, that if we're looking at neuroplasticity, and that's some of what may be going on with TMS, where we're actually causing new connections between our neurons and they're talking to each other more. It seems to me that it could potentially be really helpful. Um, and the microplastics question, oh, that's a great question.
Well, we're going to have you back to answer all our questions, of course. But
I
we
love it.
actually,
I love it.
even that time, we have more questions. So is TMS similar to alpha stim cranial electrotherapy?
That's a really great question too. So, yeah, it is similar. It is similar. The difference now is that we're using magnetic pulses. So there are lots of devices out there that do stimulation uh, using electrical current. Uh, and the magnetic pulse that we're doing, well, that is causing electrical
But it's
reaction.
different. Yeah,
But
different.
that's the difference. And listen, I am a fan also of trying these other electrical pulses. I don't have my a presentation set up for today for that one, but I have my Fisher Wallace. I have my Fisher Wallace, and I have patients that do use the Fisher Wallace and have had great effects from that as well. So similar, but a little bit different. The mode of action that we're using on that, but wonderful, wonderful question,
Okay. And
truly.
are you going to talk about the seizures? Do
Oh,
we know how it causes seizures?
yeah, I'm going to talk about seizures. Thank you so much. Let me fast forward here. I think, oh no, maybe do I thought I put it in here. Oh, I guess I didn't. Well, let me just talk about it. So as far as seizures, we have never had a client that has had a seizure. Uh, the the rate or the risk of seizure less for the whole course of treatment is less than 0.1% for the whole course of treatment. And we actually have treated, and it's not a contraindication to treat somebody who has epilepsy, but they are stable. They've been stabilized, haven't had a seizure within the last year. They've been stabilized, and this has not precipitated a seizure. But the risk is you are stimulating your neurons in here, and you are causing, especially with the high frequency pulses, which is the one, again, that is FDA cleared for the treatment resistant major depressive disorder. Um, that is stimulating. It's stimulating. So there is that risk. Again, we have not seen it. The consultants that we have worked with, while we were starting, um, they haven't ever had a client that has had a seizure either. Certainly, if a potential client is experiencing uh, unmanaged epilepsy, that's absolutely a contraindication. We're not going to risk somebody getting worse in what they're experiencing through the TMS. We don't want to do that at all. But yeah, that is something I talk about with every single client during our consultation for sure, that there is that risk. There is that risk of seizures. So I do want to say during the treatment, um, clients are never alone. All of the TMS technicians that we work with, they all have been trained in seizure protocols. Thank goodness we have not had to use that, but we are prepared if we ever do need to um, jump into action on that. But clients are never alone during that 18 and a half minutes that they are going through treatment. Um, and veering off here. So sorry. But I know I'm saying 18 and a half minutes. There is, interestingly, another treatment protocol that is also FDA cleared. It's 3 minutes. Uh, I didn't come up with this word. It's called theta burst. 3 minutes. I don't know how they come up with all these words. It kind of sounds like a Marvel kind of a show thing, but Theta Burst, where they condense those 18 and a half minutes into 3 minutes, and it's been shown to be just as effective. It's just that it is per the client. For somebody who the regular treatment protocol is totally, they're handling it so well, pain levels 0 out of 10, and they're like, this is easy peasy, I like sitting here. This is okay. Uh, we can try the more condensed version, but it's more intense, is what it is. Instead of a light tapping, at least our machine, there's other machines out there, but our machine that we use, instead of we're doing 30 pulses in 3 seconds, it's tapping on your scalp, and then it pauses for 10 seconds. It's like a zzz, 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 zzz. It's just more intense. People are conscious during the whole thing, but it's per the client if they prefer to give it a try. The 3 minute versus 18 and a half minutes with that one. At any rate, I veered. Thank you so much for bearing with. I just looked at the time, 12:55. Oh my goodness, you guys are all so kind, truly. Um,
It's
I'm
not
probably
bad. It
give.
just means we'll have to have you back because we normally don't
Oh,
have any questions. So
Yeah,
it's
this
really
is
good.
exciting, actually.
oh, I love
There's even
that.
another question. What about for
Oh,
Tourette?
mm, that's a great question too. So we're not treating the Tourette's. We're not treating Tourette's, but we have had some clients with Tourette's. So it's not FDA approved for Tourette's the to treat the Tourette's, but uh,
But
the
depression and OCD, yes. And he has those
yes,
too. Hmm.
yes. So the Tourette's, the one thing with the Tourette's is we need to make sure that somebody can be able to be sit in the chair without moving. Um, the hands are free to your free range of motion in your hands and your legs. But the head, it depends where the tics are. So if the head is moving, um, our machine that we have, it would be challenging. But other than that, we certainly can treat folks that do have Tourette's, and we have had clients with Tourette's. But because the treatment arm, it's placed lightly on the scalp, um, on that left prefrontal dorsolateral cortex over here. Uh, we just don't want movement there. So it's really quite precise when we do the mapping so that every time somebody comes in for the session, it's in that same position. Uh, so,
Wow. We have even more questions. I can't even.
oh,
But
I
what
love
about,
it.
no, we've never had this many questions. I have to tell you, we've been
Wow.
doing this
Oh,
like 9 years now or something, and these questions, this is great.
I
But
love it.
what
Love
I
it.
want to do, since we're out of time, is how about if Shar can give you a transcript of the chat because that's got all the questions in it.
Oh,
And we even got questions about abdominal stimulation because there's serotonin there. Um,
yes,
so yeah, so this is exciting. Um,
it
and
is exciting.
yeah, and then there's one about home TMS therapy machines because I've seen them online and stuff. So okay,